This month, CE from the medical directors and for the Region 8 is SEPSIS, and it's really an important topic. Before we get started, I want to do a bit of a disclaimer. Some of the things I'm going to cover in here are some national standards. Some of the things are particular to CDH, and I'll make references to that, and our CDH system. So your system may have a little bit different protocol or education on it, and the hospital that you take the patient to may have a little bit of different sepsis response protocols. But essentially this is the information that you should know on this very important topic. I want to thank everybody for letting us do this. It's really kind of a fun opportunity to be in front of the entire region. So surviving sepsis, kind of the EMS role in patient care is what we're going to focus on. Now, whenever you give a lecture, and this is not intended to be a lecture but more of an introduction, a good lecture should consist of 3 parts. You want to tell them what you're going to tell them. Number 2, you tell them. And then the third part is you summarize, or you tell them what you told them. So this part is I'm telling you what you're going to need to know out of the lecture. You'll get the lecture, and then it's up to you to kind of summarize it yourselves and take away the important parts. The Surviving Sepsis campaign is a international campaign that was started many years ago. These slides some of the slides that you'll be seeing are from a presentation from ASEP and Dr. Tiffany Osborne, who's the chair of the critical care section of ASEP's, the American College of Emergency Physicians. And they set forth guidelines for implementation of sepsis care and the future. And some of the, you'll be able to tell which slides are from that article. The very first real big article that came out on sepsis was by Dr. Rivers, and it was in the New England Journal of Medicine in the year 2001, in November. And you think, well, gee, an article from 2001, and we're just now talking about sepsis, and hospitals are just now gearing up. Well, it kind of shows you the glacial speed that hospitals sometimes take to adapt to change. Also, it does indicate that over that period of time, the mortality rates and morbidity rates for sepsis have slowly kept increasing to the point, as you'll see in some of these slides, that it's now become a national concern and a national expense for the government. So the Surviving Sepsis campaign is geared around early detection, which is where you guys come in, and ladies, early antibiotics and cultures, which is where the emergency departments get involved, and early treatment. And the treatment part is called early goal-directed therapy. And we'll define that a little bit more, and you'll see the how that plays out in just a second. So on the next slide, you'll see why is this a problem? Well, today there's over 750,000 cases of severe sepsis per year in the United States. And severe sepsis is defined as having a dramatic a change in at least 2 vital signs and or needing intensive care treatment. This is patients that do get hospitalized for infections may not qualify, but if they have significant changes to vital signs and or require ICU or ventilator care, that sort of thing, that's considered severe sepsis. The mortality rate for severe sepsis is between 20 and 40%, depending on what hospital you're admitted to, so it's not insignificant. On the right side of this slide, you'll see the future, and some of this didn't print out, but basically on the far left bar, that's the year 2000, and it tracks in the red line the number of cases of severe sepsis and projected out to the right in the year 2050. The blue bar is cases and more of sepsis if they only went up 1.5% per year. And what you're going to see is that by the year 2050, they anticipate, given more of an exponential increase because of aging and that sort of thing, that you're going to have over 1,500,000 or doubling of the cases of severe sepsis. So they're trying to get ahead of the curve at this time so that they can lessen the red line and keep it closer to the projected blue line. And so the mortality rates are less, and patient care and quality and morbidity is kept to a minimum. When you compare to other diseases, where does sepsis fit in? Well, you can see on the next slide, on the left bar, the blue graph, that severe sepsis, the cases are much greater than even congestive heart failure, breast cancer, colon, and cancer and AIDS. And this is a statistics from the National Center of Health Statistics and the American Cancer Society. On the right bar is the mortality from severe sepsis, and you can see that severe sepsis rivals acute MI in mortality per year, and as far outdoes breast cancer and AIDS as far as mortality rates. So the Surviving Sepsis Campaign, it's a global program, as I said. It's to reduce mortality rates, improve the standards of care, and secure adequate funding for the future. The guidelines that were proposed back in 2001 were not the final guidelines. Over the last decade, the sepsis guidelines have changed to where it's now very much a best practice. In most emergency departments, the importance of sepsis care is just now coming to the forefront. At CDH, we've recently instituted a sepsis response team that when the patient is felt to be in early sepsis or meet certain criteria, it mobilizes our intensivist as well as other nurses who do rapid response within the institution to assure that the care and resuscitation of the patient is put into the protocol and that all the parameters are met. Each hospital will probably have this kind of response team as we go along. So who gets sepsis? Well, the very young get sepsis, and Dr. Ari Habis is going to give you a presentation. He's the director of our PEDS ER here at CDH, so I won't go into that area too much. The other typical at-risk population is the very old, 65 and older typically, not 62 like me, so I know what you're thinking. Comorbidities. Comorbidities are things that are disease processes that add to the problem of and the risk for the patient to becoming sepsis. Comorbidities such as diabetes, hypertension, chronic congestive heart failure, those that smoke and or chronic use of medications are at risk for sepsis. A couple things that came out when I was preparing for this lecture was the importance of skin integrity. Anybody who has skin breakdown, a chronic use of steroids are going to be at risk for sepsis and cellulitis. Then also patients, as you age, you're more prone to getting urinary tract infections. This, I can illustrate this. The last 2 shifts I've worked, I've admitted 2 patients to the ICU for sepsis. The first one was a 54-year-old lady who came in with cough and wheezing. She had a history of asthma, and her pulse rate was over 130, her pulse ox was below 90, and her findings were that she was at a severe risk for respiratory arrest based on our new protocol. So she did go to ICU. The other patient we had was a gentleman with just cellulitis, and he turned out to have a bacteremia and ended up in ICU also, and he was 62 years old. So it's not necessarily the elderly of 80 or 90-year-olds that have it, and both of these patients had normal blood pressures, and I want to emphasize this point, that you want to identify these patients before the blood pressure changes, and that's one of the key goals to what we're doing. The other patients that are at risk are compromised immune systems. If you're on chemotherapy, steroids, if you have HIV or AIDS, those kind of diseases make you at risk for sepsis. So what do we look for? Well, there's some subjective criteria and objective criteria. The subjective, right, the reason they may call you to come assess them and take them to the hospital is weakness, malaise, fatigue, decreased appetite, confusion, and chills. So even though they don't sound like those are life-threatening or terribly important reasons to mobilize 911, if given the right clinical setting, they can be early indicators that the patient's on the road to having severe sepsis and or going to septic shock. The objective criteria are tachycardia, tachypnea, hypotension, hypoxia, fever, and decreased urinary output. What I want to emphasize here is this is where you come in by your assessment. The patient might be, based on your findings, you can determine that the patient has a high risk for sepsis, period. So let's talk about, just to make sure we're all on the same page before I go on. You'll see in many articles EGDT, which is early goal-directed therapy. And what this is initiating treatments that are goal-directed and proven to be best practice. Over the years, this is pretty much agreed upon that these, if you initiate these practices, you will save lives over time. SIRS, S-I-R-S, is a systemic inflammatory response syndrome. Now, this is the equivalent of being pre-septic, or the signs and symptoms that the patient may exhibit before they go into septic shock, before the blood pressure changes. So this is an early clinical presentation indicating sepsis. So SIRS, what we're looking for and what we're asking you to look for is that if the patient exhibits 2 or more signs of SIRS, then that puts them in this category of high risk for sepsis, and then the rapid response and treatment protocol is initiated. I want to just compare the ED and then how I would view EMS's role and what we would consider as 2 or more signs or symptoms based on EMS. For the ED or hospital protocols, it's elevated temperature, elevated heart rate, elevated respiratory rate, and a white count or left shift. Well, obviously you're not getting a white count or left shift out in the field. And just for completeness, a left shift is when on the blood count the white blood cells are immature, and it means the body's under stress and it's releasing these white cells as quickly as they're formed to go fight the infection. And it's an indicator when you have a high left shift, a high amount of immature white cells, that the patient's under stress and that the body's doing its maximum to fight infections. For the EMS side, for this, it's going to be temperature, heart rate, respiratory rate, and I would add mental status change and a history of decreased urinary output to the criteria. And you'll notice again, blood pressure is not a part of it. If they're already hypotensive, they're already meeting the criteria for septic shock. We're looking to catch these patients early so that aggressive treatment will keep them out of shock states. What happens when they get to the point where there's a blood pressure change is they get end organ failure. And we can talk about what that is next. So the early goal-directed treatment would be for cardiovascular support. You want to save the heart. You want to treat the hypotension aggressively. And even tachycardia, you want to treat it aggressively with IV fluids. Respiratory, if they're hypoxic or tachypnic, you want oxygen support and or early intubation if needed. Renal oliguria, meaning decreased urinary output. Again, aggressive fluid therapy is the mainstay for that. And if there's confusion, that indicates there's some neurologic change to the patient, and this is going to be probably improved with oxygen and with the aggressive fluid treatment that you guys will provide. So the next slide is kind of a sample of a 6-hour sepsis bundle, which is the early goal-directed treatment that we talked about. And you can see here that they obtain a serum lactate level. Lactate's been shown to go up if the patient's tissues are being hypoperfused, and then it indicates early septic shock is imminent. Both the patients I mentioned early had lactate levels of one was 44 and the other was in the 60s, so both elevated. We grab early blood cultures and give antibiotics within 3 hours, treating hypotension with fluid boluses and maybe up to 3 liters of fluid. Our emphasis today would be that if you determine these patients are at risk, that you start giving them aggressive fluid therapy. But again, assessment of the lungs to make sure don't have a history of heart failure, and you're not, because that could be the great fooler here, and you don't want to add fluid volume on somebody who's already fluid loaded. In the emergency department, we would also add vasopressors if needed. Internal monitoring, which is the central venous pressures, mean arterial pressure monitoring, and also early intubation if needed. The 24-hour bundle, as you can see, is glucose control, giving them Zygris, which is the directrocogen alpha, and this has been a very potent medication that has decreased the mortality rates significantly for sepsis. However, it is extremely expensive and only given by the intensive care doctors or infectious disease doctors in most institutions. Early steroids to help decrease the inflammatory response, and then obviously mechanical ventilation when needed. The third part of this then is developing data and outcome data. We'll need this to show improved mortality rates. I don't know that we'll ever get to where there's sepsis centers, like for now we have stroke centers and the centers that take care of acute MIs and percutaneous intervention, but that may be down the road. So we want to try and get ahead of this so that you can recognize sepsis early and treat it aggressively when appropriate, and then we continue that treatment once they arrive. The future is collaboration between EMS, emergency medicine, and critical care, and trying to make this a seamless, appropriate response to these patients. So as you go through the lecture, look for these key points. They'll get into more detail, and I appreciate your attention and time and letting me kind of introduce this topic to you.